Ladies and gentlemen, you've probably gathered that patient safety is a hot topic and will remain so for the foreseeable future. And indeed, risk is all around us. We all make personal decisions about risk. I can decide if I want to stop smoking to reduce my risk of lung cancer or heart disease. I can tell my child to learn the Green Cross code to cross the road safely and reduce the risk of being run over. Now, while we can identify risk, we can actually also quantify risk. Now, if you go up in an airliner, you've got a 1 in a million chance of having serious harm or death. And in Air France, it might even be higher than that. Your risk will quadruple if you participate in extreme sports such as bungee jumping, and it'll double again if you go on a roller coaster ride. If you go anywhere near a hospital, your risk is 1 in 300. And the risk of any harm at all happening to you is actually a colossal 1 in 10. Now, who cares about patient safety? If I asked you all to raise your hand if you cared about patient safety, you'd all do it, because this is 2013. When I was a lad in training, we didn't talk about patient safety, we didn't see any problems with it, and nor did we hear anything about it in the media. In fact, corporately, we didn't care. We actually didn't give a monkeys about it. And in fact, when something went wrong, we said, well, it's just one of these things. And you know what? The patients said the same. Oh, the doctors did their best. It was just one of these things. And this perception was reinforced by popular culture. Now, many of you will not recognise any of these figures on there, or Sir Lancelot Spratt, Dr. Finlay's Casebook, Dr. Kildare, or Carry On Doctor. But doctors were put on a pedestal. You didn't challenge, and that's the way it was. Ladies and gentlemen, it all changed in 1992. Stephen Bolson was a young anaesthetist, first appointed job, Bristol Royal Infirmary, cardiac surgery children. He noticed that there was a number of deaths, perhaps which were unnecessary. He did an audit, and he presented it through the correct channels, and it was blocked. It was blocked by the profession. He was fortunate in that Phil Hammond, who of course is half of that duo Struck Off and Die, the comedy duo, a journalist and GP, was working in the Bristol area at the time, and he got to know of this, and he wrote a column in Private Eye called Medical Balls, under the pseudonym of MD. So Phil wrote about it in Private Eye. It was picked up by the Daily Telegraph, and then it went viral. And before you know what happened, you had the Bristol scandal on your doorstep. Now, Bristol changed healthcare in Britain forever. And not only did the Bristol inquiry have a report, there was learning from the report. What messages could we take from this horrendous scandal where 34 children died unnecessarily and countless others became brain dead? Yes, 2 doctors were struck off and another one was suspended for 5 years. These were the short-term implications, but the long-term implications was what the government was going to do. They had to act, and they had to act very quickly. And they acted quite strongly for once. White paper after white paper was produced in quick succession. We had the new NHS, modern, dependable, which meant that from 1999, NHS trusts had a statutory responsibility for clinical governance. Then we had a first-class service, which introduced doctors' appraisal and actually formed the formation of NICE. Supporting doctors, protecting patients was regulation of doctors, and of course, revalidation, which has taken 14 years to get round to having done this year. Now, one of the first papers to champion clinical governance came from Gabrielle Skelly and Liam Donaldson. Now, Skelly had been the Regional Director of Public Health in the Bristol area during the scandal, and Liam Donaldson was Regional Director up north at the NHS Executive. And they produced a paper for the BMJ on the 50th anniversary of the NHS, and their definition of clinical governance remains one of the best to this day. A framework for organisations that are accountable for improving the quality of their services and safeguarding high standards. Governance has 4 aspects: professional performance, that's technical ability; resource use, which of course is efficiency; risk management; and patient satisfaction. And that diagram you see in this slide was published by Scally and Donaldson in their paper. And it shows a normal distribution, quality at one end, poor quality at the other end, and they wanted to shift that graph from the left to the right. Liam Donaldson then became Chief Medical Officer for England in 1998. And one of the first things he did was he got a roundtable discussion of the good and the great from industry, from healthcare, from the airline industry, and they discussed patient safety. And there are three recommendations from an organisation with a memory. First of all, patient safety incidents should be reported and analysed. There should be an open culture in the NHS. It should be transparent. We shouldn't have a blame culture. And for goodness sake, we had to actually learn from our mistakes. We had to have active learning. Now, one of the good and great around that table was James Reason, Professor of Psychology at Manchester. He'd already written a couple of books in that decade. One was Human Error, and the other one was looking at the risks of organisational accidents. And up until this point, we all thought that accidents followed the domino theory. One thing led to another and all the cascade. But James came up with another alternative theory, which you're all familiar with, is the Swiss cheese model of accident causation. This is a very recent model, only in the last 30 years. And he contended that there were several levels of failure. First of all, you had organisational influences, whereby your structures and processes may actually be inherently unsafe. Or the processes may be right, but the supervision on the shop floor, if you like, might be not so good. He also suggested there were preconditions for unsafe acts, in other words, an accident waiting to happen, and then there was the unsafe act itself. And each of these could be active or latent. In other words, actually happening at the time or just waiting to happen. And as you know, each slice of cheese represents a barrier to an accident. The holes represent active failures and latent failures, and when they all come together at once, you can see the red line, which is the trajectory of an accident, and he quoted a trajectory of accident opportunity. And that has been the theory of NHS safety and accidents since 1990. Let's go back to where we were in our timeline. We realised that we had to create a reporting and analysis system, hence the birth of the NPSA, and also the NRLS for reporting accidents and incidents. And in fact, the NRLS has now got the biggest database of incidents in the world from which to learn. And the NPSA analyses these and looks for trends. These are some alerts, guidances, toolkits and reports culled from the years 2008 to 2012 from the NPSA website. After 2012, the NPSA was incorporated into the Health Commissioning Board, and it's changing again this year. So I was only able to put these forward. You see at the top there, the next one down, risk of skin prep-related fire and an operating theatre. Thank you, Scarborough. And then there was how-to guides for VT assessments, root cause analysis tools, WO safety checklists, and so on. It's a very good read if you go to their website. Now, like everything else, nobody bothers about anything until it costs money. So the National Audit Office became involved in 2003, 2004. They analysed nearly 1 million incidents, and they categorised them into these well-known groups that you see on the screen: falls, medication errors, equipment incidents, documentation errors, and communication failure. And they put money onto it. 2 billion, they reckoned, was lost in extra bed days due to patient safety incidents. 1 billion for hospital-acquired infection. And another 2 billion for litigation which is outstanding. Now remember, this is 10 years ago. Multiply that by inflation and think what the figures would be like today. At the same time, internationally, we had to look at the WHO. Formed as part of the United Nations in 1948 and responsible for looking after international public health. And they realized in the 1990s that they were getting reports from all over the world about large numbers of patients harmed and killed by medical errors. And on their 55th anniversary, they passed a resolution to strengthen the safe healthcare and monitoring systems. And they did this through creating the World Alliance for Patient Safety, and their UN envoy was actually Liam Donaldson again. They also took as their motto that basic tenet of healthcare: first, do no harm. Primum non nocere. Now, I believed that that came from the Hippocratic Oath or the Hippocratic movement. But when you think about it, why would a bunch of Greeks put a strapline in Latin? They wouldn't do that. And in fact, it doesn't come from that at all. Recent evidence has indicated it came from Thomas Sydenham, the so-called English Hippocrates. Now, Sydenham trained in Oxford during the Civil War. He treated smallpox. He introduced tincture of opium as a painkiller. He introduced quinine for the treatment of malaria. And he also put his name to Sydenham's chorea, St. Vitus dance, which of course is caused by beta-hemolytic strep. It's an autoimmune reaction in the basal ganglia, and the children after rheumatic fever, they've got jerky movements of the arms and the legs, the sort of thing that you'll see from your president tonight after a glass of champagne, won't you? Right. Sorry, Mark, about that. Now, the World Alliance for Patient Safety has had 3 global challenges, and I'm only going to refer to 2005 and 2008. Healthcare-acquired infections in developed countries run around 5 to 10%. In developing countries, they run around 10 to 20%. And this diagram you'll see in almost every hospital in the UK and worldwide. It's the United Nations 5 moments for hand hygiene in healthcare. Now, I'm going to come clean with you. This is my own hospital, Milton Keynes. We're just there. You see, just north of London, that Google map. You know, in the old days, you said home counties north, but never mind. It's got 400 beds, serves a population of 350,000, and look what happened when we washed our hands. Surprise, surprise. Our incidence of MRSA and Clostridium dropped. Now, I can see you saying to me, well, hang on, a lot of this is in medical wards. What's it got to do with day surgery? Well, don't be so quick. Let's look at some day surgery data. Surgical site infection, over 6% in 2 studies. And I have no more recent data than these. There's been no other studies published. So if you have a study on wounds infection after day surgery, let us know, because I reckon it's not 0, and we must keep our guard up and remember to wash our hands. It's nothing to do with wearing ties or white coats, Mr. Blair, Mr. Brown, Mr. Cameron, and your sidekick. It's nothing to do with that at all. It's all to do with washing hands. Now, by the mid-2000s, the government realised that the pace of change was too slow. So they thought they would harness the skills and expertise of a number of organisations, agencies and so on, the College of Surgeons, the College of Anaesthetists, BADS and AFPP and all the other groups all participated. And at the same time, it all came together with the global patient safety challenge of Safe Surgery Saves Lives. We had these national campaigns between 2008 and 2011. In England, it was Patient Safety First. Scotland, it was a Scottish Patient Safety Programme. In Wales, it was the 1,000 Lives campaign. And there was also a campaign in Northern Ireland. And BADS played its part. We put a whole issue of the journal in 2009 together for patient safety. And I think it did work. The main reason for these campaigns was to highlight the surgical safety checklist, which the NPSA wanted introduced in every hospital by February 2010, and that was achieved. The next bit of patient safety belongs to NICE. NICE was now getting some teeth, and they got their teeth into VTE assessment and prophylaxis. You can see that in the mid-2000s, they were estimating that 25,000 people were dying each year from preventable hospital-acquired venous thromboembolism. And they brought out their 2010 guidelines, guidelines number 92, and that's basically saying that everyone needs to be assessed. Now, you could say, well, hang on, day surgery, we don't really need that, but look at the risks. We're saying any operation over 90 minutes, and let's face it, more of us are doing longer operations on a day case basis than ever before. And if you look at box 1, you probably struggle to read it from there, but you're saying age over 60, dehydration, obesity, BMI of 30. It's all there, and we really have to take this quite seriously and do the assessment for every patient and decide whether they need no prophylaxis, stockings, or heparin. Now, never events is one of these buzzwords that we hear all the time. Adverse events that are unambiguous. that are serious and are usually preventable. The term was coined by Ken Kaiser in the States, the executive of the National Quality Forum, and it was first used in 2009 in Ara Darzi's High Quality Care for All paper, which was a summation of the previous 5 years' work on the new pathway. We now have got the Never events on the Department of Health website. There's 25 of them. You don't need to know them all, but you do need to know that the ones in red are all Never events which can occur in and around theatre. Theatre is a very dangerous place, and we must not let our guard down. So, I'll sum up before heading on to Ian. I've talked about Bristol. I've talked about the introduction of clinical governance. We've mentioned the important paper of an organisation with a memory. We've talked about cheese. We've talked about the World Alliance for Patient Safety, WHO checklist, VT prophylaxis, and finally Never events. So, and Never events, I'm afraid, is one of these terms which is becoming popularly used in the press for lots of different things. And I'll give you some examples of Never events outside the healthcare environment. Now, here you see that the driver is concerned about safety. He's wearing ear defenders. Unfortunately, he's distracted, so this is an active failure, and he's about to hit some unintended consequences. Here, the father clearly has not done the safety checklist before putting the child on his shoulders and giving him an ice cream. So that clearly is a complete failure, and that's a Never event. And finally, Kylie, after a recent concert, well, is this a Never event or a serious untoward incident or just simply unintended consequences? Ladies and gentlemen, if you're enjoying these talks, Ian will show this again, but we've got a brand new booklet out from these talks are taken from it. It's available on the bad stand and they are selling fast. So thank you very much indeed.
Thank you very much indeed, Doug. Well, Doug's given us a very good generic overview of patient safety, and particularly the important timeline of how we got to be where we are. And I'm going to focus a little bit more about the specifics for the ambulatory pathway. And I suppose the first thing we could do with asking is, actually, is day surgery safe? And the best way I can answer this is by showing you a Danish study with an excellent post-operative registry of nearly 58,000 patients. And of those patients, they had 24 deaths occurring within 30 days, a fairly reasonable mortality rate when you consider what will be the mortality rate over a month in the general population not having surgery. But perhaps most reassuringly, they concluded that there were none of those deaths definitely related to specifically day surgery. But of course, there's a lot more to safety than just death. It is a fairly crude indicator. And safety is fundamental to the whole of the patient pathway. In fact, it goes right back to the very beginning of the pathway, where it's important to determine whether the patient actually wants or will benefit from having the surgical procedure in the first place. Do the risks actually outweigh any possible benefits? And are they fit enough now? Will they ever be fit enough to undergo surgery safely? And this, of course, again underlies the importance of early and thorough preoperative assessment. Getting the right surgery done, making sure we've got the right side. The best way to avoid this, again, is consistency, avoiding copying things down and writing it again and again and again, because sooner or later the wrong side will crop up by chance, and once it's in the notes, it's very hard to get rid of it. Of course, we have the patient as our ultimate arbiter who can say, look, doc, the lump's on this arm, not a problem. But beware the patient where there are no localizing symptoms, who's absolutely convinced that the surgeon told them their left kidney needed to come out, but actually the scans all show it's the right kidney that's got the disease, for example. Of course, we have our final check. We've already heard about the WHO safety checklist, which has been brought to us by the airline industry with its excellent record of safety. And they've obviously got something to be very smug about there. Let's get even more specific to ambulatory surgery, and perhaps the best place to start would be our selection criteria. We don't regard ambulatory surgery as suitable for everyone, but we have broadened the criteria enormously in the last few years because the outcomes are still good when we take on the more complex patients. But nevertheless, to manage these patients safely, they do need additional skills, additional resources, additional time. They may need the more appropriate, more senior staff to be present. They may require extra assistance, extra equipment, and so on and so forth for safe management, not one for the SHO to be doing on their own. We also talk a lot about the importance of an escort, a carer for the patient, to be able to provide support and backup and hopefully to reduce risk by being an extra person to keep an eye on the patient, providing assistance and so on. And those of you who are in the session in here immediately before this talk will have heard more about that. And indeed, as the focus of that particular talk was saying, that patients are increasingly living alone, and while it's possible to get support from family, friends and neighbours, what about the others? And should we actually be denying the benefits of day surgery to those patients who do live alone and can't find someone? You know, is inpatient care necessarily a safer and better option for them? And in fact, the official guidance has been changing. In the past, it did used to say that there always should be a carer after any procedure, particularly under general anaesthesia, but in the most recent guidelines it's been softened to say following most procedures. And the sort of groups that were thought to be perhaps suitable to not have a carer will be relatively short procedures where there's been a full recovery with minimal pain and relatively little hangover effect from anaesthesia or analgesia. But maybe we could go a little further even than that, and thank you to the presenters before me for exploring that. Abstract A3 if you weren't at the session. Francis Chung has done some work on this in Canada. Although they insisted on a carer, a number of patients probably told porkies and no one actually turned up to pick them up, and they let the patients go home anyway, or in most cases. And they found that those patients did not appear to fare any more adversely than the patients who did have an escort. No increase in readmissions or unanticipated admissions. If you are sending the patient home by themselves, it's essential they don't drive home, because this will happen. And again, we have evidence from Canada of at least 3 patients who all had fairly minor procedures, in many cases just under sedation, but they had benzodiazepine sedations and they had serious car accidents on the way home. So they must not drive home. Which of course brings me to the issue of resuming driving after surgery. And again, there is quite good evidence. This is from actual patients having actual surgery, put in a driving simulator at various points after their surgery, and their performance was recovered within 24 hours of a general anaesthetic and, in fact, a knee arthroscopy. It was a North American study, so these are probably automatic cars with left foot, left knee arthroscopies, but that's beside the point. It does illustrate the point, however, that in certain cases there will be a need for a longer period to abstain from driving if you've had a painful groin hernia repaired or various other limitations that may extend the period. But from anaesthesia, it's 24 hours. Fairly unique with our patients, although increasingly with inpatients as well, the patients are coming from home on the day of surgery. So if we want them to do things before surgery, we've got to tell them in advance before they leave home. And in particular, that relates to things like fasting, taking their medication, and also preparing them for the post-op period. It seems fairly fundamental that in order to have a safe induction of anaesthesia, you want your patients to be adequately fasted, and why not err on the side of caution and just fast them for as long as possible? But actually, that is adverse as well. And rather than worrying about whether the patients are fasted for long enough, we should now be worrying about making sure the patients are not fasted for any longer than is necessary to ensure that their stomach is empty. Currently, the guidelines recommend 6 hours for solids and 2 hours for liquids. But in the case of liquids, that may actually be a little conservative, because the stomach emptying for, if I can make this work, for solids is quite slow and is perfectly linear, but the emptying for liquids is much, much shorter and is also exponential. So half of the liquid is gone within 10 minutes. Half of what's left is gone within another 10 minutes. So really, within an hour, there's precious little of that liquid left. So 2 hours is probably still very conservative. And by allowing patients to drink closer to their surgery, we can avoid a number of adverse consequences. mainly fairly soft things like thirst and hunger and anxiety and drowsiness, but if they fast for long enough, hypoglycemia too. Now, admittedly, this American study had a fairly long period of fasting, but the average blood sugar in these healthy females was 3 millimoles per litre, and 14% of them below 2.5. That's a fairly significant safety risk, I think. Of course, if we don't fast patients excessively long, it makes it easier for them to take their medications, and in most cases, it's far safer for them to take their medications. Oral hypoglycemics would be a cracking example of where we'd want them to avoid their drugs, but other ones that are more controversial would be angiotensin-converting enzymes and ACE inhibitors and anticoagulants. Now, we know that if patients take their ACE inhibitors or their receptor blockers, that they are more likely to get a little bit of hypotension on induction of anaesthesia. But to be honest, we can manage that. You give a little bit of vasopressor, you can correct it fairly easily. Okay, what's the harm in asking them to leave the drugs off? Well, the harm is that if you ask them to leave off one drug, they often leave off all their drugs. And we know that if they withdraw their beta blockers acutely, that is quite positively dangerous. And I think it's far better we tell patients to have all their cardiovascular medication and be sure they take their beta blockers than to worry about a bit of hypotension because they're still on their ACE inhibitor. Another one that seems fairly obvious, the antiplatelets, the anticoagulants. Obviously, if the patients stay on these drugs, there's a greater risk of surgical bleeding. Seems sensible to stop them. But then, why are they on those drugs? If you stop the drugs, you run the risk of blood clots, strokes, and particularly, if they've got drug-eluting stents, of stent occlusion. Now, this really is a serious complication. Patients with drug-eluting stents need to be on dual antiplatelet therapy for a year. And if you stop or temporarily withhold that treatment within the year, then about 25 to 30% of those patients occlude their stent. And if they occlude their stent, 60% of them have an MI, and about 20 to 45% of them die. This is a serious, serious complication. So you really mustn't stop these drugs. Defer the surgery if you can. Consider just carrying on with them on and take the risk of extra bleeding. Possibly drop off one drug, but do it only in consultation with a cardiologist. Now, it all sounds straightforward, and pre-assessment clinics can sort this out. But what about the patient having a minor procedure under local who bypasses pre-assessment and gets given the wrong advice by a junior doctor in surgical outpatients? Beware. What about safety after discharge? Again, a fundamental of day surgery. This is all about avoiding and detecting complications, and probably the area that has more complications than anywhere else is good old laparoscopic surgery. So much so that the National Patient Safety Agency issued this rapid response alert about failure to recognise post-op deterioration. And the Association of Laparoscopic Surgeons produced this very comprehensive list of many signs and symptoms that, when they occur within the first day or so of a laparoscopic operation, suggest that a complication is quite likely. I prefer the gynecologist's approach, where they've simplified it somewhat and said, basically, if you're not getting better quickly, something's wrong, do something about it. Much, much simpler. And that brings me to the hospital safety myth. Hospitals are thought to be safe places. Now, if you manage someone having an operation as an inpatient, then we tend to give them opiate analgesia because we don't worry about the sedation and so on. We expect them to be sick. We expect them not to eat and drink for a while. We expect them to lie around in a bed for a while. So a slow recovery is actually the norm. It's what we expect. It delays and masks the occurrence of warning signs. We don't see the dizziness, the tachycardia, and all those warning signs. Furthermore, the patient feels safe. So if they don't feel terribly well, they don't tell anybody because they're convinced they're being looked after and it'll be spotted. Whereas, in fact, if they're recovering from a relatively simple elective procedure, they probably won't be the biggest priority on the nurse's plate. It'll be the sick acute admission that came in a couple of hours ago. There is no question that bad things can happen in hospital. Moving on. If we go back to the list produced by the Association of Laparoscopic Surgery, I think that most probably all of those warning signs should be easily detectable by patients at home, providing they've been given appropriate warning. And therefore it comes down to patient information. Now, we've talked many times at BADS meetings about patient information leaflets, and you can write your own, many people do, but it's a difficult, frustrating process, and keeping them up to date, keeping them consistent is even more difficult. So an alternative that's worth considering are a variety of commercially produced standardized information leaflets, and BADS a couple of years ago endorsed leaflets produced by one particular company, IDO, who have got a stand here with us today. And if you do subscribe to this service, you can get customized leaflets customized with your hospital's letterhead. That's the example here. But the basic information is absolutely standard. And if we look at the Lapcoli one, for example, and just focus in on the warning signs, here we've got those key indicators: pain that's getting worse, dizziness, feeling faint, feeling sick, things that are getting worse after a couple of days. If you're not continuing to improve, contact someone. And here's the importance of providing patients with an appropriate phone number. Now, in an ideal world, it should be one number to ring for everything, preferably to your day unit. But of course, if you've got a traditional day unit that closes at night, what do? Think about trying to get that number to automatically transfer to an acute surgical area, so the patient only has to remember one number. If you can't, give them an alternative to use and tell them when that number should be used. But it's important that wherever they call is an acute surgical area, because only those areas are used to managing and dealing with acute surgical complications. The GPs haven't got a clue with things happening in the first few hours after surgery. A&E have, but you might wait 4 hours, or nearly 4 hours anyway, just a fraction short of 4 hours, before anyone gets round to seeing you. And if you ring the helpline numbers that are produced sort of nationally, NHS 111, God help you. So provide them with some appropriate follow-up areas. Ladies and gentlemen, just to summarise, I think we've both showed you that just as ambulatory surgery requires the whole patient pathway approach, then safety is also integral with the whole pathway. It's everyone's responsibility, and in day surgery in particular, it's enhanced by effective communication and consistent information. And as Doug says, we have really only scratched the surface. So we've put a lot of this information in our latest booklet. I won't plug it any further, but we'll happily take questions. Thank you very much indeed.